Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. It's my pleasure to facilitate the CGNE Seminar Series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, addressing the medication M of age-friendly care through interprofessional collaborative efforts, will be presented by Dr. Nicole Brandt, professor at the University of Maryland School of Pharmacy. Not only has Nikki shared her expertise with us previously, but she works very closely with our director, Dr. Donna Fick, for over a decade on the Beers criteria, as well as work with IHI, and including travel recently to Qatar. So we're super excited to have you join us here today, Nikki. But before she's formally introduced, we do have some announcements and disclosures. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn either one contact hour or one pharmacotherapeutic contact hour for APRNs. Partial contact hours are not awarded. The topic of this education is clinical. However, our presenter does not have any relevant financial relationships with ineligible companies. Certificates will be emailed to RNs participating that meet all the requirements within 1 month following the seminar. And as a reminder, we are recording the seminar. Also, there will be a Q&A discussion session after the presentation. If you'd like to participate, please enter your comments or question into the chat, or you can use the raise hand feature and Jenny will unmute you so that you can speak aloud. The post-evaluation link will pop up in your browser when the seminar concludes. It will also be emailed to participants within 24 hours. This is required for RNs seeking contact hours, but we also ask that all participants complete the evaluation to assist with our data collection. If you have any questions or feedback for us, you're always welcome to reach out to us at cgne@psu.edu. And now I'd like to introduce Aza Al-Hassari, a CGNE affiliate graduate student who recently presented her studies examining the quality of life among older adults with post-stroke impairment at the 2025 Gerontological Scientific Annual Conference in Boston. Yeah, we were super proud of Aza and this important work. And thank you, Aza, for being here today to introduce our speaker.
Thank you, Janice, and you're welcome. Dr. Brandt is a professor and Park Davis Chair in Geriatric Pharmacotherapy in the Department of Practice Sciences and Health Outcome Research, and Executive Director of Peter Lamy Center on Drug Therapy and Aging at University of Maryland School of Pharmacy. She was named the 2019 recipient of the American Geriatric Society Dennis Janikin Memorial Award for her leadership in geriatric education. Dr. Brandt has been active in promoting optimal care for older adults and has affected this through her educational, clinical, as well as healthcare policy work. She co-led an initiative that led to the University of Maryland, Baltimore, and the University of Maryland, Baltimore County to become the first university in the state of Maryland to receive age-friendly university distinction. She has directed projects with multiple stakeholders, focusing on Medicare Part D medication therapy management programs, high-risk medications, and medication stewardship. Her public policy advocacy occurs on both a state and national level. She is one of the authors of the American Geriatric Society Peers Criteria and the past president and board chairman of American Society of Consultant Pharmacists. She was a Fulbright program specialist from 2023-2024 with the University of Helsinki School of Pharmacy to work on age-friendly care initiative. So let us welcome Dr. Brandt. Thank
Well, thank you, Azza. Thank you and congratulations to you for your presentation at GSA on a very important topic. And welcome, everyone. I put in the chat box, if you have a moment, please introduce yourself. I know I can't see you, but love to know who's present, whom you're affiliated with, and if there was one question you're hoping to get answered today. It is holiday season, so what's your medication wish list question? I may or may not have an answer, but 'tis the season of holiday spirits. So I hope I can convey that in this talk together. I'm going to share my slides. And again, thank you for this opportunity to my colleagues and especially my good friend and colleague, Dr. Donna Fick, for her amazing work through the years. So hopefully technology won't fail us and it'll work well. But as you can see, like many of us, we have multiple hats that we wear in our day-to-day practice. And I do encourage, if you have any questions, please email me. And some of the resources I'll be talking about are housed within our Lamy Center website. So I don't have any disclosures with ineligible companies, as I mentioned in my disclosure statement, but I am passionate about this work and I'm very passionate about working with interprofessional team members. So I just want to do a promotion for the upcoming American Geriatric Society meeting. I know it's going to be virtual, but there's going to be some amazing programs. And as a program chair, I'm so excited by the content. So I'm hopeful that some of you will be attending with us. And as mentioned by Janice, I've been privileged to work with Dr. Fick and others with the Institute for Healthcare Improvement. And I'm actually, some of the work I'll be speaking to has been funded by the John A. Hartford Foundation. But being a fellow New Yorker, I really loved the call out for the state, Penn State and its communities. And I think it's so important that we continue to partner together, especially during some of these challenging times within our environments. So what I'm hoping to talk about in this 45 minutes or so is I know that the work that you're doing, you're very familiar with age-friendly care, but I want to take a deeper dive into the medication and maybe some of the efforts that are happening across the care settings in which you practice, whether it's nursing homes, it's the hospital. And again, as a pharmacist on the team practicing age-friendly care, how can we work as an interprofessional team to move this work forward? And I'll share some of the efforts we've been doing in the pharmacy field. And then I hope that by working together, we can continue to adopt and implement this work across the care continuum. And I know we have some of our regional champions I'll speak to in Pennsylvania that was working with some of the colleagues in the facilities in Pennsylvania. So I'm really excited about partnership and collaboration to move things forward. And so I strongly believe in teamwork. I practice what I teach and preach, as I will in this 45 minutes. And I think Andrew Carnegie said it quite nicely. It's the ability to work together towards a common vision. And in this construct, we're talking about age-friendly care and meeting the needs of our older adults and who care for them. And this ability to direct individual accomplishments, and oftentimes in academic environment, we think about it or individual accomplishments, but it's really towards organizational objectives, and we're in this together mentality. And I love the last part of it. It's a fuel that really allows common people to attain uncommon results. And as we work as a team, and I have through my whole life, whether it's on a sports field or on a platform as AGS or in my clinical settings or in our housing work, it really takes the team. And I'm really proud of the team that I get to work with across these different care settings. So with that age-friendly care, I know that this group is probably familiar, but I was told that we might have some students. So I just want to kind of give a little bit of a backdrop. It is age-friendly health systems, which is part of the age-friendly ecosystem. And I think when we think about work, we need to think about the bigger ecosystem. Health systems are a major motivator of us as clinicians, but it also is a major economic driver of our communities. And I think with the age-friendly health system movement, it really has helped to break down silos between communities and institutional settings like hospitals or nursing homes. And what I love about it is it's a simple framework. And I'm just using quotes that I've heard through the years that I've been doing this work. Is it really helps to simplify the conversation that you are having maybe with an older adult, with a patient, with a clinician who doesn't practice in geriatrics. And really resonating that person-centeredness of the work we're doing. This model is meant to improve the quality of care, and we'll share some of the evidence that's been mounting, and I know some of the evidence that you all have up in the work that you're doing in Pennsylvania as well. So I think this has just been a very important part of the work that I've been doing with others across the country, but also, as mentioned at the beginning, across the globe, that this model is really persevering. And so when we think about the medication M, and again, I'm going to take the deeper dive in the conversation, really focusing on the medication M. If medication is necessary, and I think that's an important spot to pause. Both Dr. Fick and I have been working with the American Geriatric Society on potentially inappropriate medications. And we'll speak to one of the references in terms of alternatives, which talks about, do we even want to start a medication? So I think that's an important aspect of, if a medication is necessary, use age-friendly medication that does not interfere with what matters to the older adult, mobility or mentation across all settings of care. So easy to say, but sometimes a little harder to operationalize, because it really means having that conversation with that older adult and or care support team to understand what matters, and then sharing that amongst the collective team. And I have to reflect, I think it was probably about 3 years ago during one of these forums, I had one of the opportunities to present to Pennsylvania on an ECHO forum. And I think what was so impressive, one of the participants said to me, they're like, Dr. Brandt, by us sharing with our consultant pharmacists what matters during care planning, their recommendations are more meaningful. And I think as we think about interprofessional team members need to know and share. And how do we do that in a collective way? So I thought that was really powerful, something I've learned from you. And as people know, as an educator, it's all teach, all learn, and we all improve together. So with that, I think when I think about medications, I think about complexity of our medication processes and the approach that we need to think about, because it's really a journey. And within the field of pharmacy and medicine and healthcare, access can be an issue. And I know within my profession, the shutting down of pharmacies has become an access issue for some of our most vulnerable populations, such as older adults. So that's just one part of the journey, but I just wanted to highlight that, because as we think about the medication journey, it begins with the initiation of a medication or the decision to honestly forego a treatment, as I mentioned. But it also puts a burden on our system, on the patient themselves, and on the care support team to follow up. And that means that there needs to be ongoing review and support for those medications. We talk about adherence. We talk about, using medications appropriately as we develop medication treatment plans. And I think that's why I love the word medication optimization. And because it's not just about deprescribing of medications, but it's about optimizing what's the best regimen for that patient. And that's where that 4Ms intersection comes into play. So when you think about the programs in which you create and the systems in which you work, you need to have a champion. And some of our own work in terms of implementation of workflow and programs and grants, you need to have a champion. And as you mentioned, my feeling on a team. And then as a collective unit, as a group, as a team working together, you need to identify the medications that you want to focus on, whether they are American Geriatric Society Beers criteria medications, potentially inappropriate medications, high-risk medications, which may not necessarily lie with a PIM. But I know as a system, when we looked at it, we continue to this day, 8 years later, still are focusing on our anticoagulants, because whether they're the direct oral anticoagulants such as rivaroxaban or apixaban, or our hypoglycemic agents, whether the insulin or the GLP-1s, those are some of our high-risk medications. And that's independent of some of our potentially inappropriate medications. And what's been fascinating, I just actually came back from the Institute of Healthcare Improvement, IHI's forum in California. There's a cohort of like-minded researchers focusing on age-friendly health system research. We talked a lot about electronic health records, not just electronic health records-based tools, but AI. And I know that we could take a longer conversation into that, and always interested, because when I say artificial intelligence, what does that mean to you? Has a variety of interpretations. But, how do we use these tools, AI tools, whether predictive modeling tools, or in my space, we've been doing some work with large machine learning and pharmacovigilance. So a lot of opportunities to think outside of what we traditionally have done, to think creatively of how do we do things collectively. And this is brought into team members I never thought I would have on my team in terms of instruction, like different types of designs and expertise in terms of informatics. So really fascinating. So I encourage us continue to grow and become uncomfortable in what you don't know, to learn, because to learn makes us better at assessing. And if we're better at assessing the situation through the data in an efficient way, we'll optimize patient care. So the framework that the Institute for Healthcare Improvement has used for the age-friendly health system efforts across all care settings is assess and act on. So within the medication M, they focus on various resources such as the American Geriatric Society Beers criteria, but they also called out potentially problematic medicines such as benzodiazepines. And benzodiazepines, for those of you maybe not as familiar, they're used for anxiety, they're used for sleep, sometimes they're used for REM sleep disorders. But we know that this class of medications continues to be utilized, and maybe not in the ideal way, because it can increase the risk of falls, it can worsen someone's cognition, and it can impair their driving. So there's lots of both public health and personal safety implications with those medications. A class that I know some of us on this call have worked on together is highly anticholinergic medications. And these can be over-the-counter medications or prescribed medications. And there are resources within our electronic health records and different tools to help us calculate anticholinergic burden. And then there's been ways in which we can then help people, and I'll share some of those resources, to maybe not choose some of those medications and give alternatives or lower doses. So, and then a colleague of ours, Dr. Andrea Schwartz, who's also been very involved in this work, especially with the VA settings, and now with the GRECs, has published something on optimizing meds using the 5Ms, which is the American Geriatrics Ads in Multimorbidity. I can tell you, as a practitioner, researcher, educator, all of my patients have 3 or more medical conditions as they get older that I'm caring for, especially in our care practice settings. This is a very high level. So the 2023 was the last year that the American Geriatric Society published the Beers criteria. It's been using consistent tables for the last several revisions. And probably the most notorious table is the PIMS table, and that's the potentially inappropriate medications. This particular table or tool, as part of the tool rather, is one that is employed by payer systems. So our Medicare Part D or Medicare Advantage plans often may exclude certain medications on the Beers criteria. So when we devise the Beers criteria, we do work with agencies such as NCQA and CMS, and Centers for Medicare and Medicaid Services. But as some of you might be interested, is the intersection with research. So we use this also when we look at coexisting comorbidities. So this tool gives drug syndrome interactions, drug-drug interactions, reactions, and renal function. And there's been pockets of work independently just calling to attention the disproportionate harm from medications, especially in patients with advanced stages of chronic kidney disease. So lots of ways a tool can be utilized. But as I say to many of my learners here that I've taught through different facets, you need to make sure you understand the strengths and limitations of a tool. Well, here's the newest tool that came out just in July of 2025. And this was an alternative treatments to selected medications on the American Geriatric Society Beers criteria. So this is fun in terms of giving us, instead of you can't do something, well, here's some alternatives. And a lot of them have some non-pharmacologic implications, especially to avoid certain things, as I have referred to earlier, benzodiazepines. So, and there's 5 principles for applying alternative recommendations in clinical practice. And I think that's really important when we think about the values and the principles in which we employ these tools to understand them. So stopping a potentially inappropriate medication is not the end goal, right? It's again about helping our patients feel better and maintain health while reducing their risk of medication-associated harms. And I say that because sometimes things can be misinterpreted. Even with our work with deprescribing, it's not to take away something, but it's to optimize their regimen so they have less adverse effects from their medications. And that's oftentimes a motivator when you're talking about a shared decision making. And instead of replacing a potentially inappropriate medication with a better one, consider, again, non-pharmacologic strategies where appropriate, and then managing those common chronic conditions. Understanding the underlying cause of a symptom or condition can help guide therapy. Again, as a pharmacist, I'm often thinking, are the medications themselves potentially causing the symptoms? So I use the mantra, any new symptom in an older adult should be considered a drug side effect until proven otherwise. And there's a whole lot of literature out there about prescribing cascades where we start treating a side effect of another medication, whether someone takes an over-the-counter anti-inflammatory such as ibuprofen, they start to have an increase in their blood pressure, then they go on a blood pressure medicine, and you can see where this is going. So lots of opportunities to think about alternatives. And this is a perfect example of diabetes. So I thought I would use a disease state that we're all familiar with, diabetes, peppered throughout my presentation today. But we know that within the construct, we mentioned that hypoglycemia is problematic, especially in our older adults, and things like sliding scale insulin or sulfonylureas put our older individual, especially at greater risk for hypoglycemic or low blood sugar events. So there are alternatives that are mentioned here, and we need to be mindful of cost because sometimes access to some of these newer agents, such as our semaglutide, might not be something that people can afford. Right. So it gives us a lot of opportunities. And I think when we think about healthcare is as we see gaps in care, we look at it as an opportunity, not as a problem. And I think that's a positive thing we need to think about. We just ended helping our older adults with Medicare Part D. Medicare Part D, for those of you, open enrollment is October 15th to December 7th, and had a really fascinating conversation with a 95-year-old. And he goes, I get this letter last minute from my insurance company. And he's like, I take 4 medicines. He's like, but I don't understand why I have to pay $100 a month for a premium for 4 medicines. So instead of him being angry, he looked at it as an opportunity to learn. And we learned together that indeed he doesn't need to spend for $100 a month for 4 medicines. So there's alternative plans. But it's interesting because many older adults don't even ask those questions. So I think, again, continue to stay curious. And so Dr. Julia Adler-Milstein out of UCSF gave this article, and I've loved this article because it's really published the importance of communication as we navigate through care transitions, which is an opportune time to use the 4Ms model. And I hope, and I'm sure that all of you in Pennsylvania are doing this across your care settings. But this article illustrated not an overly complex case, but I think something that is probably what we can relate to. An 86-year-old woman, she's coming from home after sustaining a fall. She's in your hospital. She has some mild cognitive impairment, and she has a history of delirium. And I know we've got our expert on the call with delirium. Her hospital chart notes that her delirium worsens if she does not wear her glasses or her hearing aids and does not maintain a good sleep-wake cycle with daily sunlight exposure. She also has mild hearing loss and visual impairment, plus needs a walker for standing and walking around her house. Her medication regimen's pretty simple, actually, right? She's only got 6 different medicines, and 2 of them are over the counter. And probably when you look at this quickly, you're like, oh, Dr. Brandt, oxycodone, an opioid. I know that's on the Beers criteria. And, but, as we navigate through, we know that managing pain, especially after someone sustains a fracture, is important. And so just thinking about that in the construct. So they follow discharge protocols. They create a discharge summary. The discharge summary, because she was in for surgical procedures, focusing on a surgical fracture, and they did not include the 4Ms in the assessment workup that was done at the hospital. Because as you probably know, in January of 2025, the Centers for Medicare and Medicaid Services put together and published an age-friendly hospital measure. So more and more health systems are doing age-friendly care. And I think there's a lot of conversation about, what exactly they're doing and then how are they sharing it with communities outside of their hospital system. So this is an example. They did a great assessment, but it wasn't shared with the skilled nursing facility. Having been on both sides of the equation, both in the hospital and at a skilled nursing facility, there's lots of reasons for system breakdowns. And oftentimes it has to do with interoperability and still potentially focusing on access to a fax machine, which blows my mind. But anyways, another conversation for another day. So they didn't get this information, and they do their own assessment, which is part of the protocol when you're going into a skilled nursing facility. So they're unaware that the patient has a history of getting delirious or what they can do to prevent that. And she doesn't get good sunlight. She doesn't get outside. And lo and behold, her sleep-wake cycle becomes disrupted. She gets confused. She naps all day and she yells out at night. And then the prescription for an antipsychotic, and we know antipsychotics are problematic in older adults with underlying cognitive issues, let alone the implications on falls, as she just sustained a fall. So ideally, as we think about improving our systems and communication, this is a great opportunity for talking about interoperability and standard protocols across the programs. So colleagues, I know, have worked with your state of Pennsylvania and others in terms of the Moving Forward Nursing Home Quality Coalition. And I know a good colleague and friend of mine is Dr. Alice Bonner, who leads this work with Amanda Meyer. And we've continued to talk with them on how we can improve communication and collaboration with our nursing homes and our different care settings. If you're not familiar with this as well, there's lots of resources through the John A. Hartford Foundation, and the Moving Forward Coalition is also a group funded by them. So highly recommend join this newsletter. I love reading what kind of work's been happening. So I think as we think about our work, we need to think about how do we implement and sustain change. So I'm going to bring this back to my role as a pharmacist. So I'm often talking to colleagues of mine from interprofessional team members, but a lot of my colleagues are pharmacists. And one of the things as a faculty at a school of pharmacy, in a center at a school of pharmacy, I am about helping pharmacists to promote themselves as part of an interprofessional team to help improve age-friendly care. Because even though we have aging within our program, it's a small, minor aspect of how our students get trained, whether they're medical students, nursing students, pharmacy students. So how do we help our future workforce become more competent, confident, and collaborative in working? So that's been part of our work, and we've worked with a professional organization known as American Society of Consultant Pharmacists, whose mission aligns well with ours in terms of improving the care of older adults. So we just finished up the second year of a 3-year project, and so we actually have our site visit coming up next week for our work that we're doing, and I'm very proud of our team. We call our team Emerge Team because we're helping to emerge the science science, especially implementation science for pharmacy and pharmacist as part of the interprofessional team. So I share this with you because as you think about work, we think about research. We're academic centers. We think about who we partner with in this particular work. So as part of our implementation work and as part of being an educator, we put together a needs assessment, and then we put together training. People like to get recognized, so we put together a digital badge coupled with an actual physical pin to recognize our age-friendly pharmacist. And we continue to think about how we sustain these efforts on a regional level. So I'll speak a little bit to that as well. And then I think what's important to think about is how do we use public data to help guide some of our approaches? And I share this with you because I'm always learning. But our needs assessment really showed there was a variety of comfort amongst our providers. Many of them were familiar with the age-friendly health system concept, but they weren't as necessarily comfortable with all four M's collectively. And the one in particular was mentation. So we actually had Dr. Fick talk with a pharmacist from Pennsylvania about assessing mentation, whether that be delirium, depression, or cognitive concerns. And so, so this work got recently published in JAGS in terms of a needs assessment. And the beauty about this work, and always more than willing to share both the survey work, is how we can replicate this in other places. So this actually helped us, and we're actually doing some work with the University of Costa Rica, who are doing their own needs assessment on helping their interprofessional teams. So that's the beauty about doing scholarly work, is the sharing and helping to build that model. So in order to further the work, and again, all of these resources are publicly available and free. Did I mention free? So, and again, we've had this out there since March 17th of 2025. So we're about 9 months into the work. Our goal is to train 2,500 pharmacists to be age friendly, and then they're part of a network that can help institute different care practices in their care settings. And I'm happy to report that we're 1,639. So we're 67% of the way there in training our pharmacist. And the things that we've gotten back, and I won't subject you to the video, I was able to do a video and interview them, but they loved that the model was, again, simple. They loved that they could be recognized for their competencies and their willingness, and they shared it with others within their care setting. So they felt like they were indeed not just an age-friendly pharmacist, but an age-friendly pharmacist champion. And I said, from implementing efforts that matter, creating champions is really key. So we continue to partner in terms of how we can improve the implementation efforts in the long-term care setting. So we took a deeper dive into nursing homes. This work was presented at the American Geriatric Society. It's currently under review. And again, can't thank our partners enough, both the John A. Hartford Foundation, the Institute for Healthcare Improvement, and ASCP. And actually their first author on this is one of our fellows. So I say that because our fellows are just our postgraduate trainees, and our workforce, our graduate research assistants, are just instrumental to helping us get this work done. But this has been fascinating in terms of looking at mapping and GIS. In particular, we use ArcGIS. We haven't updated this in the next 6 months, but this was given as a tool to our regional champions to see what facilities were in their area that they could work with and who they could recruit into these efforts. So again, we've been aligning the Moving Forward Coalition. And I think it was the RISE PA worked with one of our champions, and they did some work together. So again, if you're in an area, just let us know. We can hopefully connect you with some people that can help with the age-friendly 4Ms and the M in particular. So we talked about these as drivers. I thought this was a fantastic paper, also published in JAGS, and senior author there is Dr. Schwartz. I think as we think about maintaining momentum, we need to think about outcomes that matter to the parties that we're talking about. So the VA in particular, they were focusing on the skilled nursing facilities, and I've used this as a springboard to share with our champions, to share with others. But you can see they were looking at really healthcare utilization. Other things within the study, and notably to me as the medication M, is they also saw a reduction in antipsychotic use and potentially inappropriate medication use. And they use this Empower framework within inpatient settings and within long-term care settings to get the pharmacist and the team engaged and looking at different factors, whether it's medications or healthcare utilization. So I think this is fascinating, and I know there's more work coming out, and really a lot of interest in, what is the return on investment for different facility types, whether it be a hospital or a nursing home or other care settings. So I'm going to focus now and shift our gear, and I want to make sure I leave time for questions and answers on the act on. So here's where we talk about the avoidance up front, but we realize that we may inherit a regimen of multiple medications. So how can we deprescribe some of these high risk or potentially inappropriate medications? And so it's really important to discuss any concerns the patient may have. Oftentimes I may ask the simple question is, are there any medication related concerns that you have? Do you feel you're taking too much medications or you don't understand your medications? Are some ways to phrase it to keep it very open-ended. And once you get into that kind of discussion, you can also say do you ever notice any problems taking your medications, kind of alluding to some of the adverse effects. And that kind of opens up the door for conversation of deprescribing with the older adult. And I think what's important is to think about then how do we document that? How do we share that? So we don't cause any deprescribing misadventures. So I thought this was a fascinating tool as people have been implementing age-friendly measures, especially in hospital systems. But the geriatric prescribing context is an electronic health record-based automated set of evidence-based age-specific dose and frequency. So Katie Drager, who's actually another IHI faculty, really led these efforts in Oregon and have been picked up by other health systems. I was talking with Hackensack in New Jersey on how they've been implementing the geriatric prescribing context. And really, it's about the mindset within the workflow is, if you're going to use this medication, using a lower dose, or if you're getting into something to order something, giving order sense that you're avoiding some of those higher risk medications. And what we've seen in the studies that were published recently in JAGS is there's been a significant reduction in dose-related adverse events among hospitalized older adults. And it also goes along with one of the frameworks of how we have behavioral sustainable change as nudging practices. So I thought that was fascinating. On the right was some work we published actually in the Journal of Gerontological Nursing. And this particular article really focused on some of the work we did in Qatar. And they started with a whiteboard. So I use both constructs because some can be very technology savvy. Some could be just starting with something basic like a whiteboard to show system change and how they looked and worked together as a team towards measurement. And in this particular, they were focusing on some of the process measures. So again, there is no one way to act on what you're doing, but I think collectively as a team, how can you integrate it, how you can sustain it, and how do you show value? So I'm going to bring back the diabetes management and deprescribing because there's been some fun publications recently on why this is so important. And I want to applaud the American Diabetes Association for really taking a forward-facing step on incorporating the age-friendly forums framework into their work and goals and guidelines. And then there was a fun publication about how we can do it from a population to a prescriber perspective. So why this is so important, kind of alluded to this before, but this was an amazing article just published in August. I gave a talk down in Georgia to a health system on 4Ms and talked about deprescribing and frailty. And I said, what better than using this JAGS perspective from both doctors Auslander and Wasserman. But we know that there's an overall overtreatment of diabetes in vulnerable individuals, and it can cause them to have more hospitalizations annually. And some of the vulnerability factors are advanced age, limited life expectancy, presence of multiple comorbidities. And so it's something to really think about. And so the 4M's framework for diabetes management fits quite nicely in terms of what matters most to patients in terms of meal and treatment preferences, goals and expectations, and using tools such as ePrognosis to look at life expectancy. And then as the medication M, treatment burden, some of these regimens where someone's supposed to take an insulin injection 3 times a day, a half an hour before a meal, check their blood sugars, or use a CGM, even a CGM, my friends. It might seem intuitive, but for some of our patients who've got limited range of motion, putting a sensor on is problematic. And then that's requiring them to get somewhere to give a sensor. And in some facilities, they won't even use CGM because of reimbursement. So affordability is not just of the medications, but of the devices that we're giving these individuals to monitor the medications we're giving. And that's all part of that treatment burden. And again, thinking about the risk of hypoglycemia, thinking about the goals of care, and thinking about some of the aspects. So the American Diabetes Association, the 2025 standards, really looks at what is realistic in terms of blood sugars, as well as A1C goals, depending on someone's prognosis. And this has been fascinating. I've heard geriatricians even say, I've had my geriatric fellow or my nurse practitioner student, actually use what is the anticipated life expectancy, and then how aggressive are we going to get with that A1C, and how liberal can we be with those blood sugars? So I think this is a great way in which to look at it. I thought this was a fun, just recently published in JAMA Internal Medicine, Diabetes Deprescribing in Older Adults. A shout out, some of you may work in managed care. This came out of the Kaiser Permanente work in California, who really moved the envelope in terms of population health initiatives to improve deprescribing efforts. So this is yet another one that's come up out of their work. And the population, and what I liked about this, the mean standard deviation of age was 80, or mean age was 80, standard deviation was 4. So those who were included in the study were adults greater than 75 with type 2 diabetes. Their A1C was less than 8%, and they were prescribed insulin and or sulfonylurea. So if you remember earlier, I talked about how sulfonylureas and insulin can be problematic, especially in our older adult. The intervention was 211 primary care physicians practices with 450 patients. They did academic detailing only, or they did academic detailing plus a patient pre-visit. So this was empowering the patient to have a conversation with the provider about what their goals of care are and what they would want. The primary outcome was to look at diabetes medication deprescribing, number of patients with reduction in dose or discontinuation of diabetes medications. Really important as researchers that might be on the call, how we define deprescribing and how we then measure it is really important too. And at 6 months, diabetes medication deprescribing was significantly greater in the academic detailing plus the pre-visit group compared to the academic detailing only. So I think that's important to know. So you can see the difference there. And then you may ask yourself, well, how do they do this pre-visit? So this was sent to the patient, getting their perspectives on their diabetes regimen, and some of the things that might be motivators for them to deprescribe the medicines, such as avoiding major side effects. And then I love this one because there's been out there for a period of time. The Canadians have some resources through deprescribing.org, and this particular one focused on antihypoglycemics. Well, the investigators actually translated this into a use tool for the prescribers on how to discontinue the medication. So it really took it down even an additional way to provide that sort of guidance. So, and I think that's what's really important as we think about, we're all so busy, and we know that it's potentially inappropriate medication, but how can I work with my patient and my systems and my workflow to potentially reduce harm? And this is a perfect example of it. Another example, I love this tool. We've been using this in our communities. It's called My Health Checklist. And you'll see our little testimonial here in the video of our work in the communities. Because I really really think it's critical. And I know we have shared philosophies and values in terms of engaging our communities across all care settings. So the My Health checklist we've been using in our practice, our primary care practice. We've also been using it within our senior low-income communities. It gives them the tools to then empower them to have conversations, not only with their prescribers and healthcare team, but also their families. So we tend to give this at the beginning of our academic year where we're doing a shared learning with a couple of our courses or our clinics, and then we reflect on it at the end of the year before the holidays when they may be seeing some family members. So again, free tool put together by IHI and the Conversation Project. So it's an amazing tool. The other resource that I want to shamelessly share with all of you is the US Deprescribing Research Network, deprescribingresearch.org. There are many webinars and programs. We're always looking for junior investigators that are interested in deprescribing work. So if you have interest in this space, let me know. We actually have an upcoming meeting, an international meeting in Montreal in April, and we have different webinars throughout the year. All of our webinars are saved, and I have the privilege of co-leading with a member from UCLA, the stakeholder group, where we actively get older adults' voices through our advisory group, but also through the research that we're doing. So that's a great resource tool. I'll highlight just a couple more resources that are in my deck, but I couldn't do this work without our team. And this is our, especially our team here at the Lamy Center. So with our graduate students and other faculty members. And with that, I'm going to share just a couple more tools. If you're in the emergency department, the Geriatric Emergency Department Coalition has resources on providing medication management in the emergency department. American Geriatric Society has resources on the Beers criteria. We've put together some web-based videos. So all of these are in the public domain. We've co-produced with our local poison center a safe medication use that is available as well. So I want to make sure to leave some time for Q&A, but the take-home points is 4Ms in age-friendly care helps us to optimize medications and really provide person-centeredness. It provides us as teams to work together, and teamwork is critical. And as I said at the beginning, continuing to encourage pharmacists as part of the team. So that is it. And I want to make sure to leave some time for Q&A. Let me stop sharing my screen here. Awesome.
Well, thank you for that outstanding seminar. The presentation was fabulous, such important information, as well as some of the initiatives that you're working on are just incredibly important. So thank you for sharing all of that. I'm going to hop right into questions because we have at least 10 of them in the chat.
Okay. And I did get my colleague from Costa Rica here. I see that she's
Yes,
chatted in as well. Yes.
Yeah. And since we only have, about 13 minutes left,
Okay.
I'm going to jump right into questions.
Perfect.
And so the first one is from one of our College of Medicine friends. Her name is Sam Fuller. She's a research project manager with the Long-Term Care RISE project. She's asking, and you've shared some of these in your presentation, but maybe you can kind of hone in on what evidence-based tools do you and your team utilize to address age-friendly medication use?
Yeah, thanks. That's a great question. So we've used, so it depends if you're looking at person leveled or a system level tools. So obviously within systems, there are some tools built into your workflow that you can use to highlight, to add to your dashboard, whether those are high risk medications or potentially inappropriate medications. And then we've also been using the anticholinergic burden calculator as a way to kind of look at anticholinergic load as a tool. On a person-centered perspective, when we're looking at medications, medications. Obviously, there are some tools that you can use to predictively model some patients that are at highest risk of having adverse events. And so we try to prioritize those within our practice setting because you may not be able to see everybody within rounds, but try to prioritize that. So some of those predictive tools. And we tend to focus on hospital discharges, nursing home discharges within our workflow for our pharmacist as part of the team. And then any referrals that we get from other team members to see them. And then when we go through a medication assessment, obviously there's some of those high risk medications we talked about, setting goals of care, understanding the patient's goals of care, overcoming, I call them the 3 A's. It's basically access. Is there an access issue where they can't get to the pharmacy? They can't afford the medications? Is there an adherence issue? And is someone giving them assistance? And so those are some of the things that I've incorporated into our standardized notes that we use amongst our team members as we look at it. So,
And if someone was interested in accessing those resources, are
yeah.
they available on your website, on that
Some of
prescribing
those things,
website? Where would
yeah.
you recommend they look?
Yeah, so we have some of the resources that I shared are on our website. Some of them are on the deprescribing. Some of them have come out in publications, Janice. So if there's particular questions, yeah, and feel free to share my slides.
Okay,
I try
that was
to
going to be my
make,
next question too.
yeah, I know
Great.
it's a really big file, so we might have to compress it or take some pictures away. But yeah, because I think it's really important to look at the literature that exists out there. When I go to a presentation, I always think, oh, what am I going to take away? So, and oftentimes I take a deeper dive into the literature that's been cited, but only briefly reported.
Wonderful. Thank
Yeah,
you. You
sure.
mentioned anticholinergics. Zara Karimi, one of our graduate students, is interested in exploring the role of anticholinergic burden on delirium. You want to comment on that a little bit?
Oh yeah, and I mean, you guys got an expert there with Dr. Fick in terms of the role. So there's a really good correlation. The greater the anticholinergic burden, the more negative implication it has on cognitive wellness and health, and the increase of risk of developing delirium. And I think part of the things that we're always looking for is how can we treat, but we also need to think about how can we prevent, right? And so I think being more proactive in terms of looking at that burden implication is a part of the aspect. And then again, when you pick up signals of delirium, you assess for it, but then how do you act on it? And this is a way that you can, again, act on it as a team to reduce that burden.
Great. And Kelly Walgast, one of our assistant deans, who's related to our Doctor of Nursing Practice program, is asking what tools are out there to measure successful implementation of the 4Ms that can easily be used in a local QI project. Our DNP students are often engaged in QI projects.
Oh, I love our DMP students. We actually take DMP students at the Lamy Center. And actually one of them is recording a hypertension talk with one of our fellows. There's so many ways in which you could do that in terms of I kind of say, look at what are some of your need gaps. So I'll give you, for instance, that we had as a perfect DNP project is we were looking at, we know that there's a fair amount of turnover in nursing staff within our health system. I don't think we're alone there. And, we have these What Matters boards that are hanging in people's rooms. They were actually physical boards. I know there's also an electronic board. So our DNP who had practiced in the setting, she's like, it's lovely, but nobody's using it. So her QI project and with the run charts and everything was to do different modalities to see how we could have more success in terms of getting the boards filled out, but getting the boards integrated in terms of what the nurses were doing. So that's a perfect example of like, what do you have that's not working? And then do a small, test of change. So we started with one unit, then we scaled up to other units, and she turned it into a presentation publication. And actually she got awarded at the American Geriatric Society for that work. So, that's a perfect example. I could go on what your needs might be, but I think you probably know those. And for me, it's been awesome to then bring in the DNP with their leadership skills and their experiences to help kind of formulate that kind of opportunity.
Great, thank you.
Sure.
So Clarice Briggs is a compliance director at a long-term care organization. She says that CMS is really focusing on psychotropics, and she's interested in how we integrate the new focus on these regulatory standards in relation to age-friendly care?
Oh, Clatrice, I have to tell you, one of our advisors is a good friend of mine. He was a state surveyor and he worked with the Centers for Medicare and Medicaid Services. I should disclaim I did work with CMS and trained surveyors. So when I first called him up, I'm like, Bill, I was like, I think I need your advice. How do we integrate 4M's care into the work that we're doing and just be mindful of the survey scrutiny? And he's like, Nikki, don't ask them to do one more thing. And I was like, don't ask them to do one more thing. Change the way in which they think to look at it. And, we've been practicing in long-term care, person-centered care, right? And resident-centered care for decades. But then how do we incorporate this? It's really a no-brainer. You've got the perfect QI. So from a psychotropic perspective, we know antipsychotics reduce mobility, increase the risk of falls. We also know that they can worsen cognition and someone's quality of life and function. But we also know some people need them. And that's, we need to evaluate that in terms of the mentation. What are we treating? Are we treating a mental disorder? Because what I've seen from our own work is that people get stopped off of antipsychotics for the wrong reasons. They have an underlying mental disorder, whether it's schizophrenia, bipolar disorder with psychotic symptoms. We've seen that own vulnerability in the overinterpretation of the regulations. So the person-centered approach is critical with the 4M's care, and the quality improvement angle that you already have embedded within nursing homes gives you the perfect opportunity to do it. And so it's not creating more work, it's just aligning the frameworks together. And it brings back joy in work. I can't tell you how many stories where both the pharmacists that I've talked to, but also the administrators are like, wow, just by shifting the what is the problem to what matters to the patient just changes that kind of mindset. So that's an outcome that sometimes we need to measure more. I wish I could have captured it in a video, but one of our pharmacists came back and she's like, I came out with the guide and I came out with this thing and I talked to the DON and she's like, oh, don't ask me to do one more thing. She's like, no, we could do this together. But they started breaking it down. One unit, one nurse, and before they know it, the whole facility became an age-friendly facility. So I just think it's instead of looking at it as another challenge or something else I have to do, as an opportunity to align what I'm already doing. So, and
I love the way you shared those stories, because that is really what we want age-friendly care to be all about, is not doing one more thing, but aligning things and making them more efficient and effective. So
yeah.
that's wonderful. So your colleague from Costa Rica is interested in how to address the effectiveness of commonly used medications for dementias, as memantine and acetylcholinesterase inhibitors. So
Sure.
interested in that.
Yeah, and I think, when you look at clinical trials, there's the translation of clinical trials into clinical practice, right? So, oftentimes in the clinical trials with these older agents, such as cholinesterase inhibitors or memantine, they look at, cognitive domains, whether it's a mini mental or a MoCA, to see if there's a change. There's also a signal sometimes within these agents that it might not just be a cognitive improvement, but it might help some of the neuropsychiatric symptoms. When they've taken a deeper dive into the tools to look at that, it doesn't always translate, but sometimes I've heard from family members, that's where that person-centeredness comes in, because there might be a little bit of an aversion to stop the medicines because they're worried, will my loved one become worse? So that's where the whole taper and deprescribe is an opportunity. So some of it's subjective, some of it's objective. I often find when caring with older adults with dementia and supporting their families, a lot of it's really subjective because there's a lot of emotion with the diagnosis, even though in today's day and age, we have biomarkers, we have PET scans, we have amyloid monitoring. I'm doing some work with anti-amyloids and it's become very objective. I'm like, please do not lose the subjective angle of the burden from these treatments and some of the things that we need to be mindful of. And I think setting realistic hopes and expectations from a medicine or a non-pharmacologic is part of our role as healthcare team members. And that gets back at the forums of what matters.
So another question related to DNP students from Beth Ann White, another one of our faculty members, looking at opportunities for DNP students to lead quality improvement projects that address polypharmacy and deprescribing in older adults while incorporating what matters in other 4Ms. I think you've touched on this, but if you could expand on that a little bit.
Yeah, so God, there's so many ways in which to tackle polypharmacy or hyperpolypharmacy, is a new term I was reading about, from a quality improvement perspective. So I'll give you an example. Antibiotic stewardship, right, is a perfect opportunity for the intersection of nurses' experience with the plentiful polypharmacy that's going on. Because sometimes they might have an anticholinergic burden and they might have more urinary tension, or they're not able to mobilize because they're on too many medicines or they're feeling dizzy. There's a lot, but then the inherent antibiotic stewardship angle of it, and diagnostic stewardship. So I know one of our DMPs was talking about her interest in antibiotic stewardship and urinary health, as an area to look at appropriate prescribing and maybe not just polypharmacy. Because remember, polypharmacy is not a number. Polypharmacy is a state where we're using more medications than are clinically appropriate. And I think that's important to note, because oftentimes people say 5 or more, 10 or more, 11 or more, or 15 or more, but it's really kind of getting back to that person-centered aspect of goals of care and what are we treating. So yeah, that's just an example, but there's so many domains in which the learner, but I think the thing that I've noticed in the last 5 years of working with DMPs in their leadership and their QI projects is make sure they have passion for it, because if it's one of my ideas, they may or may not have the same passion that I do about it. So I think that's just one of the things that I've learned working with DMPs, but they've been amazing. And I have to say, I'm just reading reflections because I teach our PharmDs with our DMPs in our communities. And our PharmDs have loved working with the DMPs based on their experiences and that shared learning.
Wonderful.
Yeah.
Well, unfortunately, we're at time, but I'm going to end with comments from Donna Fick. A wonderful presentation. This is fabulous and helpful as we think about how to better educate the nursing workforce. She does talk about whether it can be applied to other disciplines. I think you've shared some good examples of that, and makes note about the GCM being important, but the digital literacy needed to sync the pump with GCM is not minimal, is her comment there. So,
Yeah.
but thank you so much, Dr. Brandt, for this fabulous presentation. We really appreciate you sharing your expertise and these amazing resources and initiatives that are happening. As a reminder to participants, please be aware that the evaluation tool will pop up in your browser when Jenny ends the seminar, and it will be emailed to you within 24 hours. So please complete that. We really appreciate your feedback. And again, thank you so much, Nikki, for this fabulous seminar today.
Absolutely. Happy holidays, everyone. Take care.